being recorded, please do keep your camera off and use the chat. So we'll dive straight in. So welcome and thank you for joining this workshop on what makes a good neurodevelopmental pathway. So this workshop has come from a piece of research that we did at CDC for an ICB area into this topic. My name's Marie Hunt. I'm a programme manager in the Innovation and Support team at CDC, and I led on this work, and I'm joined by Adiba.
I'm Adiba. I'm a project coordinator in the health team.
Just to say before we get stuck in, there's lots to get through in this workshop. I've tried to fit as much from the research in as possible, so we don't have kind of time for reflections and questions as we go, but please do write any reflections or questions you have in the chat and we'll be happy to try and get back to you on those. But it's also, yeah, if it's too much of us talking, then do feel free to take a screen break at any time and then come back, and we won't be offended. So that's who we are. It would be lovely to know who you are. So please, can you let us know who you are in the chat, your name, and also why you're interested in this work? That would be nice for us to have a look at later and kind of reflect on. So I'll leave you to write your name and why you're interested in this work as we make a start. So what did we do? What was this piece of work about? So we were commissioned by an ICB to undertake a research project into principles that make neurodevelopmental pathways effective for children, young people and families. So we defined kind of an ND pathway for the context of this work as being a higher specialist set of services that assesses children with neurodevelopmental needs, usually autism and ADHD, but some include Tourette's and or fetal alcohol syndrome disorder, which we refer to as FASD throughout this report. They take multi-agency approaches to meeting the needs of children and families. And when we talk about effective, we mean that children, young people and families are having more positive experiences and having their needs met in a more timely way at every stage of the process. So for the kind of purposes of this project, we included autism, ADHD and FASD assessment and support within the kind of umbrella of the ND pathway. This was because the ICB that we were commissioned by had seen a noticeable increase of children and young people being diagnosed with FASD, and they wanted us to kind of include that within the research. FASD is often not included within wider ND pathways. It is sometimes, but I'll go into a little bit more detail about that in a few slides' time. So the report lays out 7 overarching principles that we kind of got from our research and from engagement work we did as well. So this is just kind of a bit around our methodology for this piece of work. So we did lots of desk research, which involved looking at academic journals and open access publications. At CDC, we also had exclusive access to what's known as the REACID study, which has a very long title, stands for the Realist Evaluation of Autism Service Delivery, and it's looking at which diagnostic pathways work best for whom and in what context. So that was a national research project commissioned in 2019 in response to the NHS long-term plan's desire to kind of find some new ways to address long waiting times. And it was a partnership between lots of different partners, and you can see who that is in the graphic on the left, including Newcastle University and the Council for Disabled Children. So the engagement study, the REACID study, started with a big questionnaire of autism assessment services across the country. And from all of the responses, they found 6 autism assessment sites who seemed compliant with NICE guidelines from that survey. So they were then selected for more detailed case studies and research. So the full study results haven't been published yet, but we were able to see those, and we drew heavily on that research for this project. And although that research study was looking primarily at autism diagnostic processes, we felt that many of the findings can kind of relate more widely to neurodevelopmental assessment and support more generally. We also looked at national guidelines and quality standards and wider demographic kind of data of the ICB area we were working with as well. So in total, we looked at about 55 pieces of research for the desk research portion of this report. We also did some engagement work. So we set up and sent out an online parent carer survey for parents in the area, followed up by 2 online parent carer focus groups and a children and young people's focus group as well. And we also identified some case studies throughout our work. So we put calls out on some of our forums, which some of you might have seen. The ICB asked us to kind of look particularly at good practice examples of the use of technology in ND pathways. So we spoke to 5 local areas, so Enfield, Durham, Gloucestershire, Greater Manchester and Tees Valley, around kind of good practice elements of their ND pathways. And we use those case studies throughout the report to illustrate some of our principles in practice. So speaking of our principles, these were the 7 principles that we identified from our research and engagement work. So this is kind of what we think an effective ND pathway should be like. None of them are particularly groundbreaking or surprising. It's all kind of quite intuitive stuff, but hopefully we have that research behind all of this now to really say that this is how we should be designing our ND pathways. So Adiba and I are going to go through each of the 7 principles in a bit more detail and some of the research behind them shortly. So a little bit of national context. So as I'm sure all of you will be aware, the diagnostic processes for autism, ADHD and FASD are set out in national guidelines and quality standards. So there are NICE guidelines for autism spectrum disorder from 2011 and for ADHD from 2018. There are NICE quality standards for fetal alcohol syndrome disorder. Those were only released in 2022, and those are based on the Scottish Intercollegiate Guidelines Network guidelines from 2019. Lots of the research was coming out of Scotland around FASD. They seem to be real pioneers in that area. We also looked at the NHS England National Framework and Operational Guidance for Autism Assessment Services as well. That was released last year. So we know that a lot of kind of work is taking place at national and local levels to improve the experiences for children, young people and families. But we know that there are lots of issues as well. So we know that there's really a growing demand for autism, ADHD and FASD assessment and support services. There's increasing concern that children and young people are not receiving a diagnosis or the appropriate support that conforms to those national guidelines and quality standards, especially around waiting times and kind of lack of support services. So we looked at kind of different waiting time data across the 3 areas. So we found that as of September in 2023, 93% of children and young people didn't receive an appointment within 13 weeks of being referred for an autism assessment. We found that there are stark variation in waiting times for children and young people for ADHD assessment nationally. So it's between 5 weeks in some places and up to 5 years in other places. And we also found that 64% of families in the UK and Ireland can face waiting times of up to 2 years for FASD assessment and often significantly longer. So this is a real issue, which we're all very well aware of. So I wanted to give a quick note on FASD. So in particular, it's gained more interest over the past 5 to 10 years. As I mentioned, NICE quality standards were only published in 2022. Compared to ADHD and in particular autism, research around FASD is pretty limited. It's particularly focused on the area of prevention. And whilst that's incredibly important, it doesn't really tell us how we can best support children and young people who are currently living with FASD. What we do know from some of the research is that FASD is the most identifiable cause for intellectual disability and the leading cause of ADHD. We know that approximately 3.2% of babies born in the UK are affected by FASD, which is 3 to 4 times the rate of autism. We know that internationally, the UK has the 4th highest rates of alcohol-exposed pregnancies in the world. And we know that there have been moves in some areas towards including FASD assessment and diagnosis under the broader kind of neurodevelopmental pathway. So this is happening quite a lot in Scotland, for example. And there was quite a lot of excitement when ICSs were introduced that that would kind of be a way and an opportunity to embed FASD pathways within existing ND pathways. That's been done in some areas. For example, in the Northeast and North Cumbria ICS. But there is concern around this as well because of long waiting lists, lack of resource, and kind of less knowledge generally of FASD amongst practitioners. So there is some debate about whether it should sit within broader ND pathways with autism and ADHD or whether it should sit in separate pediatric pathways. Just want to be really clear as well that although there are some similarities in terms of needs and behaviours, we know that FASD obviously fundamentally differs from autism and ADHD in that it has a direct cause, which is a fetus being exposed to alcohol, and that it is therefore preventable. Autism and ADHD don't have a single known cause and they cannot be prevented. So just want to make that clear as well. And when we talk in the research about prevention, which a lot of the FASD research applies to, that's only obviously referring to FASD, not to autism or ADHD. Also, just want to note that there is a difference between fetal alcohol syndrome and fetal alcohol syndrome disorder. So, fetal alcohol syndrome is diagnosed on a more kind of set series of clinical features, but FASD is a broader diagnosis that will encompass patients with fetal alcohol syndrome and others that might not meet the full criteria but still have needs. So, in the spirit of being needs led and focusing on needs, we decided to focus on FASD rather than FAS. So, that's just a note there about FASD. So, I'm going to hand over to Adiba, who's going to touch on some of the research behind the first principle we identified.
So the first principle was that a neurodevelopmental pathway should be accessible to everyone. There were a few factors that can act as barriers to accessing services. These can be financial, organisational, cultural, and social. These factors can be worse for certain groups in society. One barrier can be stigma and cultural perceptions. You might find that some cultures and people from some ethnic backgrounds have different perceptions of what type of behaviour is considered inappropriate or maybe linked to diagnosis such as ADHD or autism. For example, in some cultures, traits associated with ADHD, such as hyperactivity and impulsivity, might be viewed as gender preferred in boys. There's also stigma around having a child with a certain diagnosis, which can cause people to feel shame or be socially excluded from communities. The second thing is low awareness. I think Marie already said the UK has the fourth highest rate in the world of alcohol exposed pregnancies, which is a big risk factor for FASD. A lack of awareness amongst pregnant women and the public in general about the dangers of drinking alcohol when pregnant is a factor in this. Language can also be another barrier. In the REACED study, the study used information from parents and carers in the form of questionnaires through the assessment process, but completing these questionnaires can be quite challenging for parent and carers, especially if English wasn't their first language. Situational barriers can also be another factor. For example, if you wanted to attend a parenting program for ADHD, it might be difficult if you're a single parent or a young parent, if you were a parent with unsupportive family or partners, or if you had childcare issues. There's a few examples. Digital poverty could also be another barrier. Although parents like the idea of having online assessments and appointments, some professionals in the REACED study felt that there might be technical issues for online assessments with some families. Also, the possibility of digital poverty, which could contribute to further health inequalities for families, especially those that couldn't access devices or high-speed broadband. So the principle and practice for prevention. When we talk about prevention here, we're specifically talking about FASD. So the research has suggested that just providing information about the dangers of drinking when you're pregnant is not enough to get people to change their behaviour. Our ability to make choices is impacted by lots of social factors out of our control. These are called psychosocial determinants. For example, ideas about the social norms around drinking can be a factor, whether you're using it as stress relief can be a factor, and your ability to access information and services that reinforce important messages. So in 2018, Greater Manchester organised a programme called Alcohol Exposed Pregnancies Programme. The focus was on prevention, early intervention, and awareness raising. Part of the programme involved working with women who weren't pregnant but who were at the risk of having an alcohol exposed pregnancy. They did some work on American evidence-based behavioural intervention called Choices. The women involved in the pilot were targeted with a wide range of interventions. They had substance misuse services, wellbeing services, sexual health services, and women's centres. So the choices intervention uses motivational interviewing and cognitive behavioural strategies to increase women's commitment and desire to change. It also has counselling sessions and contraception counselling sessions. So the initial findings from the pilot showed that it showed quite positive behaviour change amongst some women.
Thanks, Adiba. So moving on to the second principle that we identified, which was that an ND pathway should be formed of a skilled and trained workforce. So that obviously came out really strongly in the research. And that was looking at kind of more general awareness training amongst health and education staff. But there were also some findings around the need for training in more specific skills for more specialist professionals as well. So awareness training and a kind of awareness of autism, ADHD and FASD amongst frontline healthcare staff, working with children, young people and families was a really key theme in the research, particularly at that prevention stage for FASD and that pre-assessment and early intervention stages for autism and ADHD. So we found some research that had found that there was kind of a major barrier to satisfaction with the autism and ADHD diagnostic processes, and that could be down to kind of a perceived lack of awareness amongst some professionals, and that was supported by other research. For example, a 2017 UK survey of GPs about their experiences of working with autistic patients, and many reported kind of lacking confidence in identifying and supporting their autistic patients. Also, some of the research found that some health professionals might not always recognise or feel confident in recognising more atypical presentations of autism spectrum conditions. So they might think that, it might look one way and only one way. So in response to training needs, lots of resources have been developed over the last few years for the healthcare workforce. I've linked a lot of them here, some really great resources. So the Royal College of GPs have developed an online e-learning course to support GPs in identifying and supporting their autistic patients. Lots of international digital training programs as well, such as the extension for community healthcare outcomes that's been rolled out really widely in America and Canada. And also some training courses from RCPCH for consultant paediatricians, experienced doctors in community paediatrics and neurodevelopmental paediatricians as well in managing FASD in community paediatric services. So lots of resources out there to support kind of growing awareness. But there are some concerns that an increase in awareness, particularly amongst GPs, might result in more referrals to already very overwhelmed services. So some of the research states that it might be better for school staff who know their pupils really well and work with them on a daily basis to be the ones who refer children and young people for assessment. So we found that despite the fact that it's been compulsory for all English initial teacher training courses to include some content around autism since 2018, there is still a lack of awareness amongst some education practitioners, and this came up quite strongly in our focus group with children and young people who told us about some of the really negative experiences they'd had at school. More specific skills for staff that work with children and young people. So in the research, strengths-based approaches came up really strongly. So being able to frame a diagnosis in a positive way to kind of strengthen self-esteem, reduce parental feelings of blame, and increase trust between parents and practitioners. Also kind of lots of research around the importance of building rapport and those skills around rapport building between parents and carers and practitioners as well. And also around kind of giving post-assessment feedback. So the REACID study found that parents really value a sensitive and positive approach to feedback, but they can sometimes find it quite difficult to absorb lots of information in one go. So that study kind of recommends practitioners taking a structured approach to giving feedback that includes using consistent and straightforward terminology, providing lots of opportunities to ask questions, even at a later stage in the process, and being really kind of strengths focused and recognizing the child's skills within that. So I'll hand back over to Adiba for the third principle.
So principle 3 was a neurodevelopmental pathway should communicate regularly with parents, carers, children, and young people. So clear, consistent communication came through as a key theme across the research and engagement work. The REACID study also highlighted this. So in the assessment process, families were confused and concerned, and they felt the diagnosis was dependent on one brief appointment. And the research has shown that when parents understand the full diagnosis process and what it entails, it can help to inform expectations. The children and young people we spoke to also felt that there was a clear lack of communication throughout the assessment process. They also wanted to know what was going to happen and when. So, post diagnosis, children and young people said they wanted to know what the diagnosis means for them and what it meant for their future, and that professionals should make this really clear. For those who didn't receive a diagnosis, parents and carers in our focus group felt that professionals don't really explain why they came to that decision and they would have liked to have known. They also wanted consistency in who delivers the message about the pathway. So the study also found that having one named link professional who delivers key messages to families around the referral, assessment process, and waiting list was really beneficial. The key professional could help provide emotional support and ensure that parents are kept up to date. This would be important throughout the entire assessment process, including post-diagnosis, where parents and carers benefited from having a named contact to go over the assessment feedback at their own pace. So the principle and practice with early intervention. Parents and carers did share that they had received an autism toolbox after the child's diagnosis. However, they felt that this should have been shared before the assessment, as it had a lot of helpful information that could support in meeting their children's needs while they waited for an assessment. They suggested that this could be rebranded as a neurodevelopmental needs toolbox, and that would shift their focus away from diagnosis to needs.
Thanks, Adiba. So the fourth principle is that an ND pathway should be multi-agency and multidisciplinary. There was lots and lots about this in the research, so we've tried to distill this down. So although the multidisciplinary team approach does remain the gold standard for assessment, as per all of the guidelines that we've talked about, some of the research we looked at the kind of possibility and effectiveness of single practitioner or abbreviated assessments. So several sites included in the REACID study had found that by adopting a single practitioner or abbreviated assessment approach, that had reduced the hours of professional time involved, for example, by replacing doctor time with nurse or allied health professional specialist time. So research that's looked at the use of abbreviated pathways, whereby children and young people with more quote unquote clear-cut presentations of autism don't go through the full assessment process, and instead they have a complex pathway consisting of referral onto a specialist team, and that's for children and young people with more complex presentations and needs, such as those with coexisting conditions. However, there's lots of challenges with that. In terms of, how do you decide on how to set the bar for who's so quote unquote complex that they require access to that highly specialist team over a well-trained local team? So that was a really contested area in the REACID study. And some of the professionals who were interviewed felt really strongly that all assessments must be multidisciplinary. And some of the parent carers and young people also worried that that wouldn't result in a robust enough assessment and that it would result in some young people being missed. Another thing that came up in the research was around skill mixing. So rather than depending on specific roles that are constrained by a professional's discipline or their banding, staffing of an assessment team can be based on skills and competence. So that might look like clinical staff, like speech therapists and paediatricians, not necessarily being part of a core local assessment team, but being available where needed. And then instead, clinicians who are available locally receive training to carry out parts of the assessment, like observational assessments that don't require such in-depth medical expertise. And the related study had found that actually lots of the sites included had already kind of adopted that approach in the context of national shortages of core staff and long waiting lists, and that generally parents and young people were happy with that approach. We also looked at kind of research into closer integration of services. So we looked at an example of an integrated neurodevelopmental pathway in Peterborough. So the pathway assesses children and young people for ADHD and autism through a single point of access. The team has a wide range of skills, and children and young people have access to therapies within the service itself. And that pathway has shown some really promising outcomes. So fewer assessments per individual, cost and time savings, and better experiences for children and families as well. And we also looked at the theme of interagency collaboration, especially in kind of relation to support for parents and carers. So lots in the research revolved around what are called parenting programs, which I know is also a contentious name, especially for ADHD. So some pathways kind of require parents to attend these parenting courses before a referral will be considered. So some of the research around that has shown that practitioners would really like agencies to work together to optimise those referral processes into those programmes. So that could look like services or practitioners with the best relationships with the family being the one to kind of raise the possibility of attending those courses. So that principle in practice at the kind of assessment phase, we spoke to Greater Manchester, who told us about their neuroprofiling tool. So this neuroprofiling tool is for over fives, developed by the University of Manchester, and it's based on the Portsmouth model, but it's a little bit different. So the tool aims to support neurodivergent children and young people while they're in the process of having an autism or ADHD assessment. So the tool includes 7 domains. They are flexibility and adaptability, well-being, motor skills, cognition and learning, sensory needs, speech and language, and activity and attention. So it was originally trialled in 3 mental health support team schools, and there are plans to roll this out more widely across Greater Manchester. So what the tool looks like in practice is that there will be a team around the young person, which will include the school, the family, a practitioner from the assessment pathway, and a representative from the mental health support team, and they will fill out the neuroprofiling tool together. So each of the 7 domains includes a checklist, information about what strategies are already in place to support the young person, what their strengths are, what's working well, and what else could be tried. The tool then highlights any significant areas of need or any gaps in support, collates all of that information into an action plan that's then shared with the young person after the meeting. And we were told that the tool really allows for the identification of joint support opportunities. So, for example, if the tool identifies that 10 children in one school need more support with their sensory needs, the assessment team can organise a sensory workshop for parents and staff with an occupational therapist from the team. And the ultimate aims of the profiling tool are to get that support into community settings earlier, to improve children's experiences and their quality of life, and to encourage more shared conversations between specialists and community services. So I'll hand back to Adiba for Principle 5.
So Principle 5 was a neurodevelopmental pathway should include support opportunities for children, young people and families, pre, during and post-assessment. So the theme of a lack of appropriate support for both children and young people and parents and carers around the pathway came out quite strongly. In the focus groups we had with children and young people, many reported the lack of support they received both before and after having an assessment. They told us that they'd have to wait years without support while they were sitting on waiting lists. And we know that some children and young people can experience negative outcomes if they don't get early support. Research has also found that people who were diagnosed with ADHD later in life regretted not receiving support sooner, and many felt their lives would have been better if they had. Other research highlighted the risks of children and young people not receiving support for ADHD, which included later mental health issues and impaired social and occupational functioning. The lack of support was felt to be particularly challenging for children and young people at key transition points. This could be the transition from primary to secondary or post 16. In recognition of the importance of transition, it's been recommended that young people with FASD should undergo when they go into independent or interdependent living situations, should undergo a reassessment to identify any changes in their needs, especially their adaptive functioning skills. Some parent and carers also would have found it helpful if during this assessment process, and this includes pre-assessment and early intervention stages, if they had some timely guidance on managing needs, on respite access, inclusive community activities, and information on some support groups they could access. So, throughout our engagement work with children, young people, and parent carers, the theme of feeling alone came out quite strongly. There was a particular strong desire for peer-to-peer support opportunities for the whole family. There was a number of reasons for this, and that included learning about what support exists in the community from other parents and carers, and the ways that other families coped and supported their children. They'd have liked to meet others with similar experiences who understood what they were going through. And siblings came up as well to help siblings understand the diagnosis, and for someone to ask the siblings how they were coping, or how they were not coping, and what strategies they could use.
Okay, so moving on to the sixth principle, an ND pathway should be personalised to the individual and needs-led. So we know this was a really key theme in the research, and we know that given increasing levels of need and long waiting lists for assessment, many areas are deciding to take needs-led over diagnosis-led approaches. So when we talk about needs-led approaches, we mean kind of early identification and faster support being the norm without the need for a formal diagnosis. And according to the REACED study, needs-led approaches and needs-led support can lead to better long-term outcomes as well as lower long-term costs on public services. But just want to kind of caveat that with, we know that diagnosis is and will remain important for some children and young people and families for many, many reasons. So the need for support to be tailored to the individual was a really, really key theme in all of our work that we did. Many parents we spoke to talked about the support they were offered either before or after their child had had an assessment, websites, online courses, parenting workshops, and many found these to be really generic and not particularly helpful for their individual child. Children and young people we spoke to also talked about the importance of support being tailored as well. We had one young person's kind of story of being offered a Lego group at school, which had been set up to support another neurodiverse young person, but which was not of interest to them or helpful to them at all. And they felt that's all the school could really offer them to support them. As I've mentioned, a contentious issue in the research and in our engagement work was parents and carers and children and young people having to access certain types of support before a referral would be considered, so having those prerequisites. So one site in the REACED study required mandatory support before a referral, such as attending parenting courses like Triple P. In that site, the time to assessment did start much later than in other sites, and that did improve diagnostic capacity. But many parents and carers felt that this wasn't helpful and it just lengthened the total time to assessment. Many parents had found the post-diagnosis support, such as Signet offered by Bernardo's, to be much more helpful. Parenting courses I've touched on, again, a really contentious issue. So ADHD research, some of the research kind of claims that there is a need for non-pharmacological interventions like parenting programs, but a lot of the research shows that parents and carers can face barriers to accessing that and gaining benefits from it, many of which Adiba touched on earlier. And many kind of just don't find them helpful at all. And we also touched on the kind of support for parents' own needs in the research as well, especially in relation to mental health problems, domestic violence, low confidence, and potentially their own undiagnosed neurodevelopmental needs as well. So what that looks like in practice at the pre-assessment or early intervention phase. So we spoke to Tees Valley, who have developed a needs-led approach to assessment and support for autism and FASD. So they went out for extensive consultation with key stakeholders, including children and families, and that showed that there were really long waiting lists for assessment. There was a really significant lack of support to navigate the system, and that families were feeling really abandoned and quite a disjointed system. So the ICB worked in partnership with parent forums across the Tees Valley. They identified the St. Helens model of support as good practice and then adapted that to fit with their local context. So I won't go into huge detail, but as part of that, they kind of developed several initiatives to kind of fill the gaps in support. So they developed a family support service with an organisation called Daisy Chain, and that was set up to help families navigate the system, to help them kind of access different support services. They set up a sensory sunflower service within their existing OT service, which is not dependent on a child having a diagnosis. They developed a new ND website with lots of kind of simple and understandable information on, and a kind of handbook developed by the Parent Care Forum full of resources. The offer of services in Tees Valley is called the Bubble of Support, which is on the right there. And that's kind of a simple way of showing all of the different support services that exist for children whilst they're waiting. They developed a multi-agency Tees Valley sleep service to kind of meet sleep needs of children and young people, and it's got its own dedicated website. And they also set up a dedicated telephone hotline for professionals such as Senkos, GPs, teachers, and early help practitioners to talk with autism coordinators before making a referral if they felt that they needed some advice, and that's shown some really, really positive results as well. So I know we're running out of time, so I'll quickly touch on the final principle, which was that an ND pathway should be innovative with technology to effectively collect and share data. So according to a lot of the research, data is currently collected within organisational silos and really fails to reflect how families interact with different services. So some of the challenges that came up around this theme in the research. So several sites in the REATED study had issues with getting the necessary questionnaires back from schools and families as part of their assessment process. And that could leave some children just kind of waiting, stuck in limbo. So one school kind of had made exceptions where one area, had made exceptions in cases where certain schools are known not to return questionnaires on time. So in that case, the assessment will go ahead with only the returned parent questionnaire, and they will book in a school observation instead. So trying to be really flexible around that. We know another challenge is that kind of those really long referral periods can mean that information collected about that child can be outdated or irrelevant by the time the assessment actually comes. And in terms of FASD, previously there were different coding methods used by different health systems across the UK, but hopefully the move to the unified SNOMED system should have improved this. In terms of kind of innovative use of technology, there was lots about this in the research. So the use of mobile technology like tablets and computers to collect observational data at school in advance of formal assessments, using educational games for assessment, having online observations and assessments and online feedback sessions as well. And also kind of using digital questionnaires, courses and websites as well to support parents and young people. There are lots of really great benefits of using technology. It can be more accessible for people that live in rural and remote areas and save significant professional time as well, but lots of barriers as well in terms of kind of varying IT systems used between different trusts, creating issues with data and info sharing, limited practitioner training and confidence in using different types of technology, and also really mixed opinions about this through our engagement work. Some parents and young people were really keen on this, and some were worried that they wouldn't really be able to fully express themselves and not have a robust enough assessment online. The important thing that came out is being given choice, parents and young people being given choice about the use of technology in their assessments. So, some final reflections before we say goodbye. Each local area's neurodevelopmental pathway will need to consider the unique needs and requirements of their own population. There's no one size fits all to this, but we hope that by embedding these 7 key principles laid out here, ND pathways will have a strong foundation to deliver effective support and better outcomes for children, young people, and families. So thank you so much for attending the workshop. I hope you all found that useful. I know it was a lot of us talking, which I apologise for, but we had a lot to get through. Before you go, there is a very quick questionnaire that we would be really pleased if you could fill out or come back to at a later date. But otherwise, thank you so much for joining, and I hope you have a good rest of the day. Thank you.